for what will be a future episode of the SNH podcast. We're live here on Health Optimization Medicine and Practice YouTube channel, and today we've got four illustrious guests and then the resident jester, that's me, haha, to talk about a very important topic, which is, topical always, healthcare, and talking about chronic disease, chronic health. And the subject matter here is from chronic disease to chronic health, and why health optimization medicine of all platforms gets this absolutely correct. So I want to just start because all of us probably have some experience with this, particularly interfacing with our current healthcare system, and just do a little bit of a story share, shall we?
True story.
We're gonna get the man, the myth, the legend, the Amsterdam assassin, Dr. Kuipers here to start. So, Dr. Kuipers, if we're going to talk about chronic disease and chronic health, let's get a little bit more into not dog sounds. That's probably bad. But more, let's get into, as you see it, you came into the health optimization medicine framework. What appealed to it or what about it appealed to you? And then also, perhaps first, what do you think is missing in the healthcare system? And I think because you're in Europe and everybody here in the US thinks that Europe has a much better healthcare system, let's chat a little bit about that.
Yeah, sure. So I work as a primary care physician, as a general practitioner, which is slightly different in the Netherlands than it is in the States, but broadly the same.
What was the name of it?
And
Yep, you gave me this cool name for what you called.
yeah, the Dutch word is huisarts, which translates to house doctor.
Mm-mm.
And
It's
so
looks
the
cool the way
idea
it's
is
written, though. I like the idea. I like the it's cool. Yeah, it sounds cooler than
yeah,
GP. That's for sure.
the idea is you have your trusted house doctor who you are partnered with the rest of your life. So he knows all the ins and outs of your family. And yeah, his
Including
goal
their
is to,
money? Is it, including how much their net worth is and so on?
I always ask because it's
Private banker meets private medicine, right?
yeah, very interesting for me to know. No, but so the Netherlands actually really does have a good healthcare system, broadly speaking, for the general population, because we as a GP have like a gatekeeper function here. You have to go through a GP to get a referral to a specialist. And so to keep our healthcare system in a small country with lots of people accessible, we do a lot of triaging. And so we provide care for everybody, but we don't really have the specialist clinics with all the top new gadgets and the top healthcare clinics. And so as a GP, what I found very frustrating is that more and more I get these consultations daily of people who are frustrated with just the disease-centric view of medicine. Like we're very good at acute medicine, antibiotics, trauma treatment, etc. But they ask me, what can I do for my health? Can I get a health check? And all I can provide them is the standard illness medicine check. And that's very frustrating to me and also very costly for care because we go along with it and we let them check their liver enzymes, their thyroid function, kidney function. And then we say, it's normal, you're healthy. But that's not really a health check, is it? It just means you're not sick. And so, as I also work as a private practice with health optimization medicine, I now know a very different way of dealing with these these questions from the market. The people want this product, and so that's quite frustrating that there's a limit at what I can offer patients who ask for an actual health check. And so I can guide them there. But my goal is to try and bridge this a bit. And I think that's something you all are dealing with. But I hope we can talk during this podcast about how we can bridge that gap.
Mm-hmm. I have a question for you.
Yeah,
Yep. I know that
sure.
that Amsterdam's got like a great healthcare system. You guys, you're just probably like everybody's walking in just so healthy all the time. Like you're managing their chronic diseases and they're all getting better on their own, right? And like you don't have to, you just tell them what to do and like they just do it in Amsterdam, right? Like no problem.
That's exactly how they do it. They don't drink, they don't party, they don't smoke, and don't never do drugs. Ideal patients. No, so the Amsterdam, most of them just they go to their fucking doctor when the engine starts smoking, and they're very sober people, Dutch people. Like, it's not broken, don't fix it.
Now, Boomer, that is sarcasm.
Yeah,
That's not bitchy sarcasm. It's just plain sarcasm.
I disagree with you, but you're just trying to poke at my ego. Anyway, as a person who's lived in probably 3 different healthcare systems now, just a comment on the Dutch healthcare system. What I found interesting, and this is just a friend of ours, she's an artist, right? And she's American, lives in the Netherlands, got diagnosed with breast cancer and they caught it kind of late. And for example, if she was in the United States, it would be highly unlikely that they would be able to afford the level of care that she needed. But because they're in the Netherlands, and this is a positive side of the Dutch healthcare system, because they're in the Netherlands, like all of the treatments covered, right? And there's no sort of question about healthcare related bankruptcies, right? Which is a huge issue in the United States. And so, when you look at people that get diagnosis and actually get through the GP, it's quite great once you get into the rest of the healthcare system if you have one of those conditions. Now, if you're on one of the proactive side of life and trying to find answers to things like why I have brain fog, it is lacking, and most medical systems are lacking. And I think Dr. Bukatz, you spend a lot of time pulling things out of people's intestines and various other orifices, right? And so want to get your perspective here on U.S. healthcare systems. Look, you're in the emergency room, and I think that's one of the things that we do well. Like if you have a broken arm, if you get stabbed in the back, if you which I guess is not really a common thing. I learned that yesterday. You have somebody that can fix it for you. But I mean, tell us a little bit more about your side of the healthcare system and what we can do.
I mean, what Yep just shared is absolutely reflective here as well. Patients will come in, they don't have typically great access to care, especially primary care. So let's just say that the management of their ongoing disease burden is already questionable, at least in the population that I work with. And actually it's interesting. Last week I had a guy who came in, and I think it highlights the story, but from the acute side that seems more obvious than when we talk about patients that have uncontrolled diabetes and blood pressure and they keep coming to their primary care doctor's office. It's harder for I think the general public to really, or maybe not, maybe this audience, but the wider general public to really understand the severity of the issue and the approach that the illness medicine world takes. So this guy comes in, he's 40s. He comes in, he was hit by a car. He was on his bike. He was not wearing a helmet. He comes in, he's got some head injuries, some lacerations. We scan him, take some pictures, we patch him up. And as we're discharging him, we see his bike, and he's like, oh, I've been meaning to get the chain fixed because every time I go down this particular hill, the chain like comes off and falls off, and then I lose control. And then, there's cars, and I'm lucky if I don't hit a car and he falls over. Right. And we go, oh, that's really, you should get that worked on. Right. So we discharge him. Right. We take excellent care of his lacerations. We inform him how to clean him and keep him dry and watch for infection. We give him anti-inflammatories, and we're very diligent about that part of it. He goes home. 4 days later, he comes back again, level 2 trauma. Bike, auto, chain story. We're like, wait, you were just here, your lacerations are fresh. And so we, put him in the magic CT scanner, right? Rule him out for any life-threatening injuries, patch him up. And we're like, all right, you really got to get that chain fixed. We're meticulous. We examine the old wounds. We examine the old fresh wounds, the new fresh wounds. And I'm sitting here like, wait, have we thought about the root cause of this guy's issue? Like why he's coming in, threatening his life. It's the issue is, it's his bike, right? It's his mode of transportation. It's the chain. And so it just highlighted to me, especially when we talked about this topic, that we're addressing the problem and we're really good about that, but we're not really looking at the person as a whole, and we're not addressing how they got here in the first place. And that's something I think that I really appreciate about the health optimization framework, is that we're looking at what is the setup that gets them to the state of illness and disease, and then we're addressing that so that in the hopes that we prevent ongoing illness and disease, and we improve their life and quality. And so, if you were to tell this story to anyone off the street, you don't really need to have any kind of medical degree to say, wow, we're spending, tens of thousands of dollars on this poor guy's emergency medical care, when really a $20 bike chain would fix all the issues. So
I love this story. I'm going to use this.
It's a good analogy overall to what's broken with our healthcare system, Alan. I mean, we know that you guys in the ER, despite what you might see on the news or whatever, like you guys do a great job. Like the work that's like, how many people actually survive like with these kinds of wounds now versus 20 or 30 years ago? It's like, it's a ridiculously high number compared to what it was. So when, acute trauma care especially has gotten phenomenally better over the years. That doesn't mean people don't suffer because they actually live with terrible injuries afterwards, which is another story. But what is absolutely broken, and I think all of us can agree, is the, maybe not as much in Amsterdam in the sense of everybody gets access to a doctor in that capacity, which is great, but just the kind of care that they're getting. And this is what I was alluding to when I was chatting and being sarcastic with you, Yap, is like, we can treat diabetes, like we can treat high blood pressure, but these are really just Band-Aids on the system, right? Band-Aids and they're really changing their trajectory a huge amount overall. And so the challenge is like, what is the system outside of conventional care, either from a preventative perspective or from an acute perspective? And this is really where health optimization medicine and practice comes in, right? And so Dr. Ted,
let me
talk to me
before we pass it to Dr. Ted, who's going to go on like a great thing. I want to just kind of let's paint an arc here about what people can expect with health optimization medicine, and then Ted can go into a little bit about what he's doing with the paper, right? So let's say somebody, and Scott, I'm going to ask you to articulate this.
Yeah.
Somebody wants what types of people approach you, and then what do you take them through?
So I think the key really is that most people want to be healthy, right? But they don't really understand what that means. Most people think that being healthy is taking their diabetic medication, their high blood pressure medication, is following the standard American diet, whatever it might be, or the next influencer they found on Instagram or something like that, and changing their protocol or something. I remember when I asked a group, an audience in 2019 or so, if anybody was taking supplements in the audience, of course, and about 95% of people raised their hand and said they're taking supplements, right? And then I asked the corollary question, which is how many people have measured what they need and are taking supplements that are directed to those deficiencies and toxicities, and maybe 15 or 20% of people raise their hand. So the idea with what we're doing over at the nonprofit at Health Optimization Medicine and Practice is to help people not have to guess, but to test and detect what they need, and not from just looking at it from a disease perspective. Yes, it's important to treat diseases; those will kill you, right? But what's also very important is to look at the health side of things. How do you keep yourself healthy? There's really no other specialty out there that focuses on, as Dr. Ted always told me when I was first starting, the basic cell, right? Understanding how the cell works, the nucleus, the cytoplasm, the mitochondria, the endoplasmic reticulum, et cetera. Like every tissue in our body has cells, and they have basic ways of working regardless of type of organ they may not be, or may or may not be. So it's a switch from this organ-based system that all of us grew really kind of focused on when we were training, to more of the holobiont system, right? Which is the idea that we have this holo organism that is us, that we are this we're very, very few in number human cells compared to other types of cells around us all the time as well. We have bacteria, fungus, and virus. We have all their environmental stuff coming in. We have toxins. We have toxic people, as Dr. Ted likes to say as well, that are interrupting our health in various ways. So how do we keep ourselves healthy? And so the whole process really is to bring somebody in and give them this perspective, number one. And most people, I think, resonate with the perspective. They don't always just want to be getting band-aids or even looking for the root causes of diseases. I mean, those are important. The root causes of this is what functional medicine doctors do. And we like functional medicine doctors. I have lots of friends that are functional docs, and they're really good to find the root cause of an illness. But it almost is, if you're just doing that without looking at the foundational aspects of health, then people really resonate with understanding that, right? Like if your cells aren't working, if you don't have foundational vitamins, minerals, nutrients, and cofactors, how are you going to treat your Lyme disease? Like, for example, right? Which is a common thing that a lot of people here in the United States will talk about is like, well, I have chronic Lyme. Well, you don't want to just treat chronic Lyme with 7 different antibiotics and call it a day, right? You really want to focus on the foundational stuff. So that's a perspective shift overall. And then giving that to people and then starting with like a full metabolic assessment, metabolomic assessment, gut assessment, neurotransmitters, hormones, and from the focus of health always, and not the focus of looking at particular disease or conditions.
All right. So, Dr. Ted, floor's over to you here. Why does this work and give better long-term results to people?
I think
versus
more germane to the discussion is, Aubrey de Grey's discussion or model of diseases and aging. No, despite the personal stuff that has swirled around him, let's not throw the baby out with bathwater. And so the popular view of diseases and aging would be, aging would have frailty, sarcopenia, immunosenescence. And when I was training in anti-aging medicine, this is really what we were looking at, right? Frailty, sarcopenia, immunosenescence, etc. And then the diseases were classified as either congenital, like Tay-Sachs, Milas, communicable, tuberculosis, malaria, and then chronic, Alzheimer's, cancer, atherosclerosis. And those are the diseases that we do in illness medicine. However, what Aubrey de Grey did was to actually divide this differently. He says diseases would be communicable and congenital, right? Um, and then aging would have specific and general components. Specific would be Alzheimer's, cancer, atherosclerosis, and general would be frailty, sarcopenia, and immunosenescence. So that particular division between where he moves chronic diseases into specific diseases of aging is actually a significant one, and says that with aging you will actually get this, right? It's expected that you're gonna get this. And so he has this aging in 3 words, which is really very simple. He says aging is metabolism, damage, and pathology, right? So metabolism, accumulating damage would be lifelong, and then damage to pathology will be late in life. So this MDP model, or metabolism damage pathology model, actually is what we've been using, or what we're commonly asked for. For example, when we're being asked for things like, when do you use stem cells, or when do you use telomere control, or when do you use suicide genes, and remove crosslinks via crosslink breakers, and so on and so forth. That's the maintenance approach that's advocated by Aubrey de Grey and that's working on the damage to the pathology side, right? The damage to the pathology side, but there is no one working on the metabolism to the damage side. So my point is, why don't we slow down this by actually taking care of the metabolism? Let's do optimizing the metabolism so that you actually decrease incurring lifelong damage, right? Before you require a maintenance. So basically, health optimization medicine uses the health optimization approach, and then for the damage, you use Aubrey de Grey's, which is the maintenance approach, right? So when we're asked about these kinds of interventions, we go, okay, that's actually not within our purview. That's a purview of the maintenance approach. And we can refer you to people to do that. But there's always a place, right? It's always a place for a fundamental taking care of your health optimization approach, of the health optimization of your metabolism, even if you already have the disease state, right? So the thinking in the health optimization framework is that, you know, the body is not perfect, and you have to optimize it, right? The thinking in illness medicine, oh, it's perfect as it is. That's why it's considered broken when you have disease, right? So it's a very different point of view to continue maintaining or optimizing. And optimizing doesn't mean that one size will fit all, right? And optimization is actually, as I said before, a mathematical or computational problem, right? It becomes very, very individual. And then longevity and rejuvenity, or the quality of life, becoming younger metabolically, are, become just side effects. So we're doing the quality of life thing by doing health optimization. If you focus on the quality of life, or you pay attention to the quality of life, then disease prevention and longevity become mere side effects, right? Because you're basically taking care of the body now, right? You don't know whether or not you or your client, will step into the street where there's a drunk driver and get killed, right? So you take care of the quality of your life now, and then disease prevention and longevity will actually take care of themselves. Now, in terms of what we're doing here, is that we're saying that, when we do, say, for example, the clinical metabolomics, which is the required module in health optimization medicine training, right? The metabolites actually signal way ahead of time, before the formation of any disease, right? Whether or not your fundamental cell, as Scott mentioned, is actually working optimally, right? So that's the key here, is that they're not disease either. We use a different range for detecting imbalances, right? We use, we use the range of a person aged 21 to 30 years old, or evolutionarily derived values, right? So and so when a person comes, for example, hey, Dr. Ted, my thyroid value is this, or my alpha lipoic value is this. Well, is that geared towards a person who's actually 21 to 30 years old? And the reason for that is that you're at the optimal time of your life in terms of survival and reproduction, right? So that's what I want to make clear in here, is that we are after the health optimization approach and not the maintenance approach. Someone's got to take care of the fundamental cell, and we are it. The other thing that I want to emphasize here is that everyone has a standard for care for a particular disease, right? Dr. Scott and Dr. Kuipers and Dr. Bukats would know that, oh, it's that standard of care. Otherwise, if you don't know the standard of care, you'd get sued, right? But however, there's no standard of care of health for health, and that's why I'm actually frowning on lifestyle medicine, right? Because they have no standard of care for health. Again, their criteria is the absence of disease. Well, that's illness medicine again, right? If you're going to use illness medicine endpoints for the improvement of health, then that's improvement of health. Then that's not health at all. That's still disease care, right? So, and as I said, it really requires a shift in the point of view, towards taking care of the fundamental cell.
All right.
I always love hearing this, Ted. So, question: as the group of docs and practitioners who practice health optimization medicine all over the world keeps growing rapidly, what would for you would be the optimal road forward for health optimization medicine? What would you like to see happen for health optimization medicine?
Can
I interject one here? Can I interject one here?
Yeah.
So if this happens, I'm retiring in New Zealand and you guys will never see me again. If you see a specialization developed in medical school, and there's a couple of this with a competing framework, which is more on root cause of disease in Colombia. But if you see this developed in 2 of the top 100 medical schools around the world as a specialization, not a or a certificate even, then I'll retire and go to New Zealand. That would be sort of like crowning achievement for me. But Dr. Ted, over to you.
Well, Boomer touched on education, right? Medical education, where medical education is actually illness medicine education, and it's just like difficult to have, to introduce all of this into the standard medical education program. In fact, we tried this on third-year medical students who finished biochemistry, etc., and they loved it, and they loved the fact that they could already train and see patients after the second year of medical school. However, the bigger aspect here is more like if you take a look at the macrocosm of the United States, the way I see it is that the American Medical Association, for example, is in charge of health. No, they're in charge of disease, right? I'd like to see a parallel organization like an American Health Association or an equivalent, really. That would parallel that, because illness medicine doctors should not be in charge of health medicine, right? So, that it's like, just do this diet, and they don't even know how to specify the diet, right? Whereas when you say, okay, you have to go into an anti-inflammatory diet, this is what you should do, or as I'm known to do, you should do resistance exercises, and then bring them to the gym and actually teach them myself the fundamentals of resistance training, right? So these are two different things. Like the people who are actually whose expertise are the root causes of health should not be under the people who are actually looking at the root causes of disease. They should be in parallel, right? And in constant dialogue with each other.
Yeah. What do you think?
Oh, no, go ahead.
Dr. Bukatz, please.
Sorry. Well, there's something that you said, Ted, that as an illness medicine doctor for the last 15 years really stood out to me was, where do we get our lab reference ranges from? So these are something that as physicians, we don't really even question it. We get a report from, one of these big corporate labs, and it has this huge range, right? And it's just, and if you fall outside of that, then it's critical and it gets highlighted and we address it. But oftentimes your doctor's looking, and all they're looking for are the critical values, or those that fall outside of this range that's given to us. And when we really dive into what that range means or where it came from, it comes from an actual, not that large of a sample population, often maybe 100, could be 1,000 people. So when we apply this across an entire population, it may not actually be representative. And then if we look at who that population actually is, they are what they refer to apparently healthy individuals is what they use. So
that's really very interesting, Alan, because the example that I usually give in my lectures is the thyroid hormone, and it's one of the things that actually was good in my training in Paris for this one, right? Because we were made conscious of the reference ranges, and the thyroid hormone is actually based on values from age 3 to age 94.
Exactly.
Right? Yep. 1,000 patients from age 3 to 94, and so it's just like you get shocked, but we never question it in illness medicine, and that's why I always say, the beginning of my lectures, I always say, just because you're not sick doesn't mean you're healthy. It only means that you're sick. You're not sick, right? Yep. And that's because of of many things. But if you take a look at it from an objective measure, we're using those ranges that say, "Oh, you're not sick." It's actually funny that after I start lecturing in that, the UK actually decreased its requirement for vitamin D to 20 nanograms per deciliter, right? And they started seeing adult nutritional osteomalacia. So softening of the bones in adults, and that's because they said, "Oh no, you're not sick at this time." Yeah, you're not sick, but you develop over time, a softening of your bones, which is like, why, we already know by evolution, right, that we require so much vitamin D because this is a highly conserved gene that has been there even before we became a species, right? It's 650 million years old, older than us. And so here we are fighting. Again, this is very Zen or very Buddhist, right? We're trying to put into our conceptual framework what should be, but that's not what nature is actually doing. It's doing something else, right? So we have this very significant cutoffs in terms of our, like, this is sick, this is not sick, and so on, right? And we get stuck there, right? Where I say, well, the nervous system is not a digital system, I always say, well, the body is really analog, and that's how we evolved. Right? We do cycles of things all the time. And so now people are now paying attention, right, to chronobiology and all the other things that we do in health optimization medicine that is not paid attention to by illness medicine. Like, for example, the time that you give your drugs actually affects, the effect of the drugs. The microbiota that you have in your intestines actually affect whether or not certain chemotherapeutic agents can be effective because they pre-process the drug and so on. And that's why I always fight. It's like, oh, is that randomized control trial? Randomized control trial, guys, did you control for the gut microbiota? And it's sort of like, and then you're met with silence, right? You cannot control all of those. And that's why randomized control trials are for acute infections, for surgical techniques, right? Otherwise, that's for acute illness medicine because it has to work for a population. Otherwise, in chronic diseases or in management of chronic diseases, when you do health optimization and you take a look at the management of the chronic disease at the same time, it is actually specifically tailored for the person, right? You cannot do one size fits all treatment or intervention, or in our case, balancing for a client in health optimization medicine. Now, I always try to say client because, when you see a client, a person seeking health optimization medicine help, right? You set aside the diseases, you take a look at the fundamental cell and say, so, well, what is the cell trying to say to you, rather than what in the cell am I going to stop, right? I'm going to stop it with antihistamines and this and that and that and that. Well, the fundamental says, well, fuck you. I was just telling you what I needed, right? So it's a different point of view on listening to the body, and clinical metabolomics has been said to be the stethoscope of the 21st century, and I think all of us, not just health optimization medicine doctors, should know how to read the metabolome of the human body.
Well, it's fascinating, right? Like, they have this apparently healthy population, and yet there's no standard for health. So, it's just not overtly diseased. And it almost makes more sense to take a subset of that population and go, all right, well, do you feel like you have the right amount of energy to do the things that you enjoy and love? Are you generally in a good mood? Do you feel like your brain is on and alive and, can think clearly? And do you feel a sense of youth, right? And then you take that subpopulation and then you have a separate set of values, which now we know from what you've described, Ted, as our evolutionary
in crass
values.
terms, and the way, and I know Boomer wants to end this, in crass terms, Alan, illness medicine makes sure you have an erection for fucking. And health optimization medicine says, okay, we're really going to make you enjoy fucking. So,
and on that note, ladies and gentlemen, please go enjoy fucking. All right.
Stay tuned for our next episode.
Next episode of Smarter Not Harder. We're not a condom company. All right.
Smarter and harder.
Yeah, exactly. Excellent. Well, gentlemen, thank you so much for joining today. To everybody who's listening here, have a wonderful day.
Thanks,
bye.
Take care, everybody.
See ya.
Good day.